although mine was, I just got back from errands.
Cool. All right, so I guess we'll start with a little bit of introduction. Well, maybe a couple more people come in. My name is Matt Fothergill. Graduated Andover 2011. I'll give you a little bit of a story about my background and why I ended up where I'm at. But first, I kind of want to get an idea of why people are interested in this topic. So who's here because you're curious for yourself, or you were a contact sport athlete yourself? Yeah, there's a lot of hands.
I just came from another class and popped into your meeting. This is Ernie Adams, class of 71. I've spent most of the last 50 years as a football coach, including the last 21 working with my Andover classmate Bill Belichick at the New England Patriots. So this is
there you go. Yeah. Wait, so how many years did you say?
Ernie.
Well, let's call it the last 50. I mean, I've been at the Patriots since we started in 2000.
We'll have to talk. I think we got a couple mutual friends, and that's part of the reason why I'm into this.
Okay.
But yeah, so that's a big reason why a lot of people are into this, because it's the personal experience. That's kind of why I got into it.
And I see, I got to give a shout out because I see one of my football buddies there, John Healey. Good morning, John.
Hey, good morning, Ernie. I'm so excited to see you. It's great. You know.
Nice. And so any questions, we're going to do the Q&A at the end too. So anyone wants to write questions about this, we'll answer them. And I'm happy to talk with anybody afterwards. We'll give you the contact info. So we got some contact sport athletes, some personal experience. Who's got a family member or a loved one who's been diagnosed with dementia? Do you know anyone?
Yeah. I do.
I think 1 or 2 degrees of separation, everybody knows somebody. There's about 800 types of dementia. So if you don't know someone with it, they haven't told you yet. Is anybody a professional in the healthcare field or in long-term care? Yeah.
I'm an orthopedic surgeon.
Oh, very cool. Very cool. I worked at hospital for special surgery. So
that's
great orthos.
Yeah. That's where I trained, and I'm a professor there, and spent my life there.
Very cool. Very cool. I loved it. Great experience. Cool. So we got some different backgrounds, a lot of overlapping stuff. So today I just want to kind of give you, like I said, a background of my story, so my career choice makes sense, and all the info that I'm about to share kind of comes together. And then I'm going to highlight some of the work that I've done using a case study for the past year and a half, and talk about all the incredible clinicians and geriatrics, ortho, neuro rehab, and long-term care spaces that are working to improve the long-term care delivery and implementation for a lot of these folks. And then we'll open it up to Q&A. It's kind of like an abbreviated version of a talk that I've done. So it's we'll get through it, and we'll do it casually and have some fun with it. So I was a new upper at Andover in 2009. Coach Mo recruited me to play. I was a cornerback, safety, punt returner. Before that, I was playing hockey, football, and baseball. Grew up playing hockey primarily, was skating before I could walk. I grew up in Arlington, just outside of Boston. So if you didn't play hockey, you didn't fit in. So that was kind of how I got into it. So contact sports early, lots of head hits early. My brother, who's just about 3 years older than me, and was definitely old enough to know better at the time, stabbed me in the ear when I was about 3. So that would have made him 6. So they had to totally rebuild my eardrum. It completely destroyed it, built it with skin for my arm and rubber. So chronic ear infections, dizziness, all sorts of neurovestibular symptoms kind of early in life that I was exposed to. So that kind of showed me all the different types of rehab that exist. So I came at it, I tore my quad in half and I sprained my ankles and I broke bones. So as an athlete, I came at physical therapy from that angle, but I also had the neuro and, like my uncle was shot in Iraq in the Marines. So I got to see a lot of the nerve kind of crossover pathways. So a lot of exposure. when I went to Andover, played football, captained the team senior year, and then got recruited a couple places, decided not to play. I didn't want to get hit in the head anymore. At that time, 2010, 2011, we were just starting to get some public notice about long-term effects of concussions. And since then, it's even drastically changed in terms of how we talk about it and what we've learned from the research. So, I mean, for example, it's not necessarily even concussions anymore. Sometimes the biggest concussions that you see aren't the most impactful ones. It's the subconcussive and the repetition. So those linemen in the trenches versus me getting hit on a cross over the middle, big hit, everybody in the stand screams, wasn't as harmful to me as it was, 50 times those centers banging into the nose guard. So that kind of all led me to the other side of the sideline and started coaching a little bit early on in college, started doing fitness, performance coaching, training. And I went to Northeastern, got my doctorate there in physical therapy. Northeastern's really, I think it's the first physical therapy school, very well known for their neuro program. So I had already had a very long kind of history learning and experiencing coaching in the orthopedic world. So I just got interested in the neuro specialty. So I did the vestibular concentration, became a vestibular specialist. So a lot of dizziness, vertigo, all those things. I treat general population for that stuff, but so much of it overlaps. Because one of the big things in concussion and contact sport and subconcussive head hits, if you get hit hard enough to jar your brain, you've also had a neck injury. And sometimes you don't need to even get hit in the head to have a neck and a brain injury. Those whiplash, I had a couple of concussions in center field diving for balls too. I definitely remember that, getting up and turning the wrong way. Like, what the heck am I doing here? So that's kind of led me down the path of very a wide experience and interest range. And I got to work, like I said, at Hospital for Special Surgery, just orthopedics. For those of you who don't know, ortho and rheumatology, best in the world. Learned from some great mentors there. I got to study in Hawaii, so I got to see a little bit of the Eastern and Western medicine combined. So a lot of yoga, a lot of mindfulness, a lot of kind of cultural things that I've brought into my own practice. And then I've worked in Florida, and so there's more cultural stuff down there too. A lot of interesting kind of treatment ideas from this Middle and South American cultures. And then I came back home to Boston, and I kind of got bored of treating 400 ACL tears a day. So I went to skilled nursing, a total 180. And when I got to the skilled nursing setting, which is a combination of acute, subacute, and long-term care, primarily geriatrics. My youngest patients were like 50s and 60s age range. At that time, it might be different kind of elsewhere, but where I was at all the places that I worked, I was the only young male athlete who worked in the building. It was a lot of older females or a lot of like younger occupational therapists and speech therapists, which is predominantly female professions. So just kind of by virtue of me looking like a lot of these older male athlete patients and them being comfortable with me, I became the specialist for them. So got to learn a lot about wound care, a lot about dementia, because every one of those places now has a dementia care unit. And then that just that became kind of my passion in my life's work. So that brought me to where I am. And then the past few years, I've been working on independent consulting. So I kind of took all of those passions from sport performance and from dementia care and long-term care and seeing kind of how people struggle to implement really excellent care in these 140 bed facilities with 2 nurses and a physician who shows up once a month. Kind of took that and had a really great opportunity. There was an awesome family who welcomed me to come on for a private contract and basically gave me carte blanche with the care plan. So totally ran the meal plan, redesigned the house, redid the whole fitness schedule, socialization schedule for a gentleman who actually coached in the NFL for a number of years, played at a high level in college, Division I. And they're suspecting now that he has CTE, which, for those of you who don't know, chronic traumatic encephalopathy. As I mentioned before, there's been some very rapid advancements in the research on all this stuff. They used to think it was just concussions, so something where you could actually see a symptom early on. The rating scales for it have completely changed in the past 5 or 10 years in terms of grading a concussion. It's no longer based on amnesia or loss of consciousness. Post or persistent concussive symptoms are becoming more appreciated in the field. And so that's kind of where I've put my energy. And so now to talk about, some of the advancements in practice, I want to talk about that case study. So for 1.5 years, like I said, I designed this whole program and had a really great opportunity and a lot of freedom to do what I believed in, using all of the information that I had. And what it came down to, I'm going to give you a couple examples. So with the persistent concussive stuff, with the long-term effects of neurodegeneration, there's a lot of sensory processing disorders, a lot of social challenges, adversities, a lot of physical barriers, a lot of physical manifestations that people don't realize. And with these contact sport athletes, it's never just a head injury. We got both shoulders replaced, both hips, both knees. Ankles have been plated and screwed together 5 times. I'm saying, like, it's everything that could be injured has been injured. And then on top of that, now you have broken down pathways from the brain to your neuromuscular system. So what we did was we adjusted the whole setup of the house. We modified furniture. We modified everything from lighting to placements of food in the kitchen to the colors on the wall and the places that the art was on the wall. And we saw over time that when we adjusted the home setting, it really gave us the freedom to implement the interventions that we know from research can work. So to give you an example, one of the biggest challenges with this case was the food. So our contact sport athletes, our high level athletes, any athlete really, we eat a lot of calories because we train a lot. And then when we stop playing, we don't stop eating. So if you don't kind of match those things up, you get all out of whack. And when we're talking about brain injuries with concussion, subconcussive head hits, and persistent concussive symptoms, the neurometabolism is all out of whack. And that's one of the biggest things that we've started to really pinpoint in the past couple of years that we didn't recognize before. Because who's had a concussion and slept the rest of the day or couldn't go to practice the next day because you just were too tired? Like I had that. There was a week, I think it was after we played Choate, came home off the bus, and it was Sadie Hawkins weekend, and I sat in my room and turned all the lights off in complete darkness, and I just slept the whole weekend. But now we kind of understand what's happening with the energy metabolism. But now we're finally starting to see the clinical implementation of intervention has a lot to do with the food and the lifestyle and the timing of all of that. So we had a gentleman who was eating way more calories than he needed, eating foods that didn't agree with him. He had a constant inflammatory pathway from the foods he was eating and the way that his body was set up from all the damage that it took. And what we had to do was find a way to get the right nutrients in him so that we could settle down the inflammatory process, allow space for his brain to recalibrate, essentially, clear some of those pathways and allow for when was it, lower year, that I wasn't there lower year, but chemistry, the Krebs cycle, everybody knows the Krebs cycle. We're talking about ATP production. We got to just hack that a little bit with the food. So what we had to do was take, I'm gonna grab my props here. I'm gonna show you one of the tricks that I used. Show you this. So it wasn't just the type of food, because anybody can say you should eat more vegetables, and then they leave your office and they never eat a vegetable because they don't like it or they don't want it. One of the tricks that I like to use, so you can see here, I'm going to compare that to this, and we'll look at them side by side. Which one looks like it's more food?
Left hand.
Yeah, same amount, same exact number of leaves. I did this all the time, and it works wonders. This works a lot for our athletes as well as the Alzheimer's. I'm not going to get into the details of all of the hundreds of dementias, but a lot of them with the sensory processing and the depth perception, tricks like this can make a world of difference in caregiving duties. You put the same amount of food on a small plate, you present the food differently. One of the cool advancements in the food, now that we're talking about that, is these gummies that they have. Has anyone seen those? There was a kid in the UK, his grandmother has Alzheimer's, refusing to eat. One of the biggest problems we see with dementias. It's either you eat too much or you don't eat anything at all. Because either you don't want to eat it or you can't you don't have any control over anything. You don't have any inhibition. So this kid, he took, his grandmother would only eat gummy bears or something, or jelly beans. So he took them and he filled them with electrolytes, and he basically like put Ensure inside of a gummy bear, and he fed them to her, and she gained like 20 pounds. And so they're starting to sell that, and I'm hoping to see that come into play in a lot of long-term care. Another thing that was a challenge was alcohol. A lot of our athletes self-medicate. A lot of our athletes who play at a higher level are stars, are the highlight of school and high school and college. And then if you make it to the pros, you're getting free drinks everywhere you go, and you're the life of the party because everybody wants to know you and everybody wants your autograph. So everybody gets that exposure, and a lot of guys succumb to it. And if that becomes an issue and you have no inhibition and you're a large human being and nobody can tell you no, there's not a lot of ways around it, except for now they're starting to make really great fake stuff. So there's about 10 different brands or so now that make really, really good, high quality, good tasting, non-alcoholic stuff. So like O'Doul's isn't the only one anymore. Heineken makes one that's outstanding, and it tastes exactly like the same thing. There's 4 or 5 other breweries that make interesting flavors of beer, and then you have a company that does spiritless spirits. So they have whiskey and vodka and gin without any alcohol content. And I've used those so many times with such great success because so much of it is social. And when you're in a place where your short-term memory is impaired, a lot of times we've got to use that to our advantage. So you stick a drink in front of someone that looks like a cocktail, and they drink it and it tastes like a cocktail. And 5 minutes later, they don't remember that they had a drink, but they're asking for another one. it's not going to make a difference because there's no alcohol in their system. You can keep pumping them with that stuff and it's not going to make a big difference. So that's a huge one that's been a massive help, that I personally would like to see start to move into a lot of the long-term care settings, the permanent settings. So that kind of brings me to another point, which is, the thesis of this whole talk here, of this kind of abbreviated version of this, is what are the advancements in the field? And I think that I hope that this has shown you guys some of the, it's not easy. It's never easy to care for someone with these challenges, but there are certain tricks. And the real biggest advancement is reverting back to how things used to be done. When you had a doctor have a house call and you did stuff in your own environment. When you have a 6'6", 350-pound guy coming into a 140-bed facility with small women who he doesn't trust, because he comes from an era where the male athletes had a very specific machismo, and a very specific kind of gender role perception. It makes a difference, and it's an acknowledgement and not necessarily a perpetuation of these unfortunate cultural happenstance. But yeah, the point really is you got to meet them where they're at, and a lot of times that cannot ever be done in a large facility with a bed that you can't fit these people in, with roommates that they don't like, with neighbors that the only activity that they do is bingo and knitting. And it just, the advancement is bring people home, bring people to smaller spaces, bring people to, a 10-bed facility, a 12-bed facility. There's a lot of people now working on this. They've been doing it in Europe for a while. We're always 50 years behind them in healthcare. Europe and Canada. They have communities. They have small communities that are designed as homes. Who's heard of white coat hypertension? So your blood pressure goes up as soon as you see someone wearing a white coat, or you see someone who's in a position of authority, or someone who's standing up higher than you and looking down at you, or somebody who's about to test you. I can't tell you how many clients I've had who've come to me from the best CTE researchers and clinicians in the world at Boston University. And they tell me, I hated it because all they did was make me feel like I was being studied and I was lesser. And when you're talking about people who their entire lives have been the center of attention and have been lauded and praised for their athletic prowess and their physical abilities, that's a big hit. It's a big hit to anyone's psyche and mental health, to be kind of looked down on, and that skews the results too, to be honest. I mean, the results of those tests are not going to be accurate when somebody's uncomfortable. I think it was.
It applies, sorry to interrupt, but it applies to every aspect of medicine,
Absolutely.
And I tell you, part of my success is I go in the room and take the lowest seat, and I've structured my office so I look up to the patient. And so it's extremely important, and it sets, so even though I'm an uptight, not this morning, but bow tie kind of, anal compulsive guy, it totally resets the equation, and particularly for minorities, I would add to your point. Sorry for
which a lot of high-level athletes now are, especially in football. Absolutely.
That's why
absolutely, it's an excellent point, and it's and it applies to everyone. I mean, it really is everyone.
It's respect for the person you're dealing with.
Power balance.
The people. Everyone's still people, and that's the biggest advancement. Because for so long we tried to move away from the buddy like house call neighborhood doctor that treats your whole family for your whole life and then they retire. We tried to go to this massive thing, and hospitals were born out of necessity because an x-ray machine, when it was invented, was the size of a building. And now we can fit it inside of an RV. So we have these big, massive buildings and this awesome, fancy equipment that really doesn't improve anything if you're not implementing the interpersonal relationship how it was designed to be. I mean, human psychology has not changed much. We just have really good technology now. That's the only difference. So it's using that technology to support the classic, you know, hi, I'm Dr. So-and-so, you can call me, you know, whatever you're comfortable with, or, you know, I'm going to be down here at your levels. The studies on body language. Oh man, there was a group out of HSS I saw at a conference. Some great studies about how it actually changes vital signs and changes perception and mental health in a long term, you know, and compliance with exercise and with treatment programs and all that stuff. Trust is the number one thing. That's the number one indicator, actually, in concussion rehab. Number one indicator of relief from avoidance of or relief from persistent symptoms. The number one indicator of success is if the person that is treating you appears confident and you trust them. They could know absolutely nothing, but if they sell you, your brain will heal. It's very, very simple in that way. Like it's, you know, you set the environment up for success. And that's what I've been talking about this whole time, right? Like lighting and body language and decoration and presentation. If you do the work to figure out what those things are for that person that you're dealing with specifically, the rest of it falls into place pretty easily. So yeah, so with that, I think I saw a couple other questions pop up. Let's see if I can find that chat there. We'll talk about those.
No, we were just talking about alcohol-free alcohol.
Oh, cool stuff, right? Oh, in Germany. Yeah, there you go. I love Ritual. Ritual is a great brand. They make a really good whiskey, and if you make a Manhattan or an old fashioned with it, it's delicious. And it looks the same too, and it smells the same, and they smoke it, and it's like it's a big deal. And I'm hoping to get those into a lot of these long-term settings, and bars too. Like, you know, like I can't tell you how many of my buddies who have had one too many, and I went up to the bar and said, "Give me a rocks glass with water and a lime, because I'm going to sneak it to them." It works. Yep, alcohol-free wine. Yeah, like the Free and what's the other one? I forget the other brand, but yeah, good stuff.
What differences have you seen in women with these, you know, post-traumatic brain injuries or other Alzheimer variants?
Yeah.
So most of what the work has been is in, you know, high performance male athletes, but, you know, increasing, you know, soccer, you know, girls heading the ball and other things, I think is the next wave of things. So what have your observations been about that?
Yes, so a lot of good research starting to come out on that. A lot of guys in the UK working on that. Yeah, like you said, it's been very recently that women are being studied for anything in healthcare. We haven't had that really ever. But in my personal experience in treating these people, one of the things that I'd like to see come out in the research to support this, because it's consistent and I see this all the time, and it's undeniable.
Mm-hmm.
What happened before the injury is relevant. Okay, so who you are and the experiences you've had prior to a trauma impact how that trauma is going to affect you. Anything, thoughts, human interactions, psychology happens in the physical world. So you're creating connections in your brain. Those things exist. We talk about the big one that people talk about is Aaron Hernandez, right? If anyone watched the documentary or listened to the podcast, I've dug into this guy for so many years now and just tried to understand what it was and tried to see how it was going to help me treat other people. And that guy had more trauma than anyone I've known before he ever stepped foot on a football field. And the manifestations of the injury does not make people violent. It makes people not have control over what's already happening inside their brain. So for the females, I see that there's not a lot of attention on it because they don't become as violent, because the people who are experiencing the long-term effects now come from a generation of females where the gender role was very different than it is today. So gender roles, culture, society, all very relevant to how the presentation of the disease is going to be. Because one of the big tricks that they teach, and actually, so Claudia Allen, who is an occupational therapist who developed a big a program for dementia care, one of the tests that they developed is it's a stitching test, because it's based on something that these people know how to do. So like all of these women who were housewives who were sewing the husbands and the children's clothes, like that's the task that they knew. And one of the main interventions that they recommend is to have them help with something, housekeeping, have them fold laundry, unfold a bunch of towels and give it to them, and they'll do it for 8 hours straight. So that a lot of the Alzheimer's, the folks with Alzheimer's that I deal with, the females, that's a big piece that I see is playing. It's hard now because of where we are in society right now. It's hard to meet people where they're at because they're living 50 years ago in their brain, or whatever it was that's, Alzheimer's, we know, is kind of a progressive, and you revert gradually through the stages of life, essentially. But the female athletes, I mean, shoot, it's gonna definitely depend on what type of athlete they are. The soccer players, generally less physically aggressive. Field hockey players, a little more physically aggressive. Hockey players, more physically aggressive. Different manifestations. It's going to depend on where they got hit in the head too. Soccer players, headers are always here. So CTE is not Alzheimer's. And this is one of the hardest things to explain to people, because Alzheimer's is we don't know exactly, but like some genetic component, but we know that it has a pattern, and it starts on the outside and works its way in. But concussion comes from specific damage to microvasculature inside the brain, and certain parts, certain cells and certain lobes of your brain being damaged and having that metabolism screwed up. So if you get hit in the front, you're having the injuries in this direction. If you're getting hit playing hockey, you're getting hit here from the side. So you have more temporal lobe stuff. So frontotemporal is bigger. Your linemen have more of a frontotemporal presentation, frontotemporal dementia, because that's the lobes that are being damaged repeatedly. But yeah, so definitely with the females as compared to the males, I would say there's some component of the female physiology, of course, that plays into it with the hormones and how those kind of interact with the energy levels and all that. We know that a lot of symptoms will become more pronounced at different periods of a menstrual cycle. That's a big one. That gives us some clues about how to prevent UTIs too, even. And that's a huge issue in the everyone, but especially the females with dementia in later stages of life. For sure. Yeah, I hope that kind of answers.
Yeah, no, that's great.
So are there any sort of earlier warning signs, right, for CTA? I know it's something you can't really diagnose so easy, but are there early warning signs for people who've had multiple concussions? We know they've had sort of post-concussive symptoms, and are there things that we should be watching out for earlier that give us a signal?
Yeah, so like you said, it can't be diagnosed until you've passed, because you have to do a brain biopsy. That's something that they're working on. They're trying to find a blood marker, but as far as symptomology, it's it's tricky because many of the symptoms of concussion and of CTE overlap with neck injury and mental health adversities. So if you were, like I said, like Aaron Hernandez had trauma before that wasn't treated. So to attribute everything that he did to CTE, I don't know. So like for him, it was like the impulsiveness. Impulsiveness becomes a big one. He got away with a lot of stuff in middle school and high school because he still had his faculties about him to not do it in public. But now we know from reports from teammates and coaches and stuff, like he started doing some weird stuff in the locker room, like in public, at bars, very kind of, it seems just abnormal to the person. Like it's an exaggerated version of the worst parts of them is what I say to look for. So just like a big exaggeration of lack of impulse control. But everything else, it's so hard to say because it has to, a lot of people don't get treated for whiplash injuries. I have a client right now who 4 years ago was in a car accident, had a concussion, went through 5 different specialists, never had her neck treated. And the primary issue is that she has limited cervical rotation to the left. And every time she gets in a car to look over her shoulder to the left, she gets dizzy and lightheaded. So like, we want to attribute that to long-term damage in brain cells. But there are certain things that can still be treated long down the line. So like specifically for CTE, a very, very pronounced difference in the person's ability to maintain social graces, essentially. But outside of that, every other symptom you see, like anger, frustration, sadness, depression, pain, dizziness, lightheadedness, vertigo, blood pressure issues, loss of balance, all of those things might be attributed to something very different and something that might be treatable, like very easily treatable. That helps.
Yeah, thank you.
What is the real state of the research being done to be able to diagnose CTE in people who are living? Because it really strikes me, we're talking about sports, and let's say particularly at Andover, you know, if you actually have some high school kids and you can look at them and say, you know what, you've got some tau showing up on your brain here, that's to me, it seems will be the real the game changer, particularly with young athletes, because I mean, I remember sitting down with Aaron in the cafeteria at the Patriots and talked to him after his daughter was born, because we all knew there were issues. We didn't know exactly what they were. And always the nicest guy. I had a great conversation with him. But he had this Jekyll Hyde personality, and we all knew he had his posse from Bristol, and there was stuff going on that the best thing in a lot of ways for him might have been to go play for the Seattle Seahawks instead of, you know, so close to his buddies in Connecticut. But it's the research, you know, if you can take high school kids and say, you know, there's a bunch of high school football players who are in the early stages of CTE, that to me will be, you know, the huge game change, because you get kids like Aaron or Tyler Sash, who played safety for the Giants, who was, you know, 28, you know, died at 28, you know, with, you know, brain, you know, totally diseased.
Absolutely. So I'll say this: there's the 2 parts to that I'll comment on. So the research is being done. They're trying to figure out how to get a blood marker or some sort of test that can figure out if you're having tau buildup or all that stuff. That probably is going to take a long time. I don't know. I don't know what's going to happen.
Long time, we talking, you know, I'm just, you know, 5 years, 20 years? Okay.
Yeah, I'd say probably within 10 years they'll have an idea of something. But the other point that I wanted to make is that doesn't need to be, and I would argue ought not be the last straw, because we do have very good we have a much better understanding of how to diagnose functional and neurometabolic dysfunction after head hits, which precedes CTE.
Mm-hmm.
So we're trying. It's weird because we're trying to solve the problem of diagnosing CTE when we can prevent the things that cause it. And we already have all the information to do that. So you see what I'm saying? So it's a tricky thing to do, because we know that if we study the metabolism, when we mess with the nutrition, and we have mental health support, and we have the right aerobic progressive overload program, the problem is not the research, it's the ability to implement that in a sport where you're playing your next high impact game at the exact moment when your brain is the most vulnerable.
Mm-hmm.
So 7 to 14 days later, if you get hit again, you're now causing the problems that lead to CTE. Those microvascular changes, those continuous breakdowns in the neurons, and the breakdowns in the mitochondria that bust open the cell and flood all the calcium in and screw up the sodium potassium pump. If we could stop that, I mean, so we know that there's a correlation between repeated head hits and CTE. We don't know if it's causal, but it's probably causal, to be honest. Like we don't know for certain, but you know, we see that it's amount of times, amount of years played and number of head hits is the most clear correlation. It's not how big the head hit was. It's not if you lost consciousness. It's did you get hit a bunch of times over a span of longer than 5 years?
Well, I mean, I'm on the practice field every day with the National Football League team, and
Yeah.
believe me, I see. You don't have to see the hits; I can hear them. I mean, you know, that's the if you're when the intensity picks up, you can close your eyes. It's what we say, make it noisy.
Yeah.
You can hear it.
It's gonna take a massive cultural shift, because everybody wants a silver bullet, right? Everyone wants a magic pill. And that's why I wanted to do this talk, because the advancement isn't the pharmacy. It's not the equipment. It's not the sensors on the helmets. It's not the fancy treadmills and heart monitors. It's changing the culture around what it means to be hit in the head. And regardless of whether or not it comes with a massive, visibly impaired person.
Well, I mean,
do you think that people are willing to have the test done? And so even if you had a diagnostic test or some, biomarker for this, I don't think the athletes, and again, based on cultural aspects from the start, are going to be willing to do it. And if they're diagnosed, they can't get insurance. There are all kinds of down the road consequences if they're
absolutely
aware of it, and so they won't be tested. You know, if you do an MRI now to say, well, do you have Alzheimer's early? If you've got plaque, you're uninsurable in so many different ways. So I think that they're unlikely to be willing to have those kind of tests.
Absolutely. It's a great point, and it's not far off from the the tests they can do on fetuses or like embryos to tell if they're going to have genetic deformities, and you can abort them if you want. Like, how many people actually are going to do that? I don't know. But like the point is the cultural shift. It's a challenge. And the thing that I do, so I consult with teams often, and athletes personally who don't have symptoms. So I consult with players, athletes who don't have dementia yet, but we're trying to prevent it. They're aware of it. They're conscious of it. One of the things that I do that's different from the people who come to me versus the people that I go to is it has to be disguised. For people whose livelihoods depend on their ability to step on the field, nobody's going to report a symptom. Peyton Manning said this a bunch of times. He flubbed the preseason baseline testing so that he never had to take a down off. Like they all do that. We know I did it, like we had the baseline concussion testing. I remember sitting in the gym doing it, and then we underreport, and then it just goes under the radar. What I do with the teams is I say, I expose your weaknesses that I can help you work on in a way that isn't going to negatively impact your brain. So I teach coaching staffs how to run a Monday walkthrough in a way that's going to incorporate, and this goes back to the white coat hypertension stuff, right? Like you incorporate into your lineup drills, your warm-up drills, certain tests that expose concussion and post-concussion symptoms and whiplash injuries. So you have them stand on one foot, or we have them do eyes closed lateral stepping. And if you got like 30 sets of eyes on these guys and you see one wobble over, when you break off into groups, then you can separate them in a way where it's not calling anybody out, because in any of these sports, most sports, and especially football, if you get called out for having an injury, if you're singled out, you're a loser. You're letting the team down. You are going to lose your scholarship. You are letting your coach down. You're letting your family down. A lot of these guys in college have kids that they have to support. But it's about designing the program in a way that's going to continue to highlight their progress as an athlete and continue to develop their athletic performance without negatively impacting their brain. So we've already cut down the 3-a-days to 2-a-days and 1-a-days, right? It's not far off from that. We've changed the kickoff rule and how that's implemented. It's like we don't have to have contact every single day. There's plenty of information to say that banging into each other repeatedly doesn't make you tougher. It just doesn't. I mean, that's the culture that needs to be changed. Because if we change that, then we have an opportunity to say, you're going to get better as an athlete if you do these visual perceptual and visual ocular reflex exercises while standing on one foot, or you're reading defense from the crow's nest, like a mile away or up on the rig, and you're practicing your depth perception, and it's all kind of focused and controlled and specific. So that's my thought on it. I hope that we can spread that like wildfire, because that's going to save a lot of lives if we implement it like that. Because it's just about, you have the brains of these athletes at the moment that they're getting hit. None of them are adults. Their brains aren't developed until they're 25. It's like infants who can't see color. You only have black and white mobiles because color is useless or it's too confusing for them. Like an 18 to 25-year-old kid be trying to understand that there's a future, like it's not going to happen. You're not going to beat that into their brain. It's impossible. You got to tell them that I'm going to make you a better athlete by doing this, and without ever saying that it has anything to do with injury or concussion or sitting out or missing time.
So I had heard about some studies that were in the military with head injuries, and I seen a study, but my daughter's doctor, after some concussion, said that there were some preliminary I don't know, potential learnings around use of fish oil and omega acids in actually faster recovery in these soldiers who have these traumatic head injuries, and that there was some clear benefit. It's kind of what you put in, baby formula, right? There's stuff you put in to promote brain growth. And so have you heard anything more about that and the impact of, let's say fish oil and omega on, faster recovery and brain health after these concussions or head injuries?
Absolutely. Omega-3 fatty acids have some of the best research for anti-inflammatory properties in the brain. As recently as like 20 years ago, the FDA was recommending omega-6 ratios higher than omega-3s, but omega-6 is actually an inflammatory, which is we need inflammation to heal. But when you have what's called the neurocascade, so you have an injury in the brain and then things around it start to fire off and it just gets all out of proportion. We overreact often. So there's too much inflammation. It sends signals to our gastrointestinal system. As far as what we understand from the most recent research, the GI system starts to open up and actually accept more inflammatory factors from food. So this is that metabolic process that we were talking about. You're losing energy. So you have the cascade in your brain. There's too much calcium getting into the cells. You can't create ATP fast enough. You're burning energy like a forest fire. You're trying to stop it. And then you're bringing inflammation in because your body thinks inflammation is going to heal. So it's not just omega-3. It's omega-3. There's a couple kinds of omega-3 fatty acids. So you have ALA and AH. There's two omega-3 fatty acids that, and this is marketing. This is the garbage marketing that we can't fall for. The omega-3 fatty acids that you find in plants are not the ones that are available or stored in your brain. They're helpful. They're very healthy. They're good for you. But for brain, it's fish oils, fish and seafood, shellfish, mussels, oysters, clams, salmon, fatty fish, tuna, right? They have the type of omega-3 fatty acid that is bioavailable to you when you're in a state of inflammation and that can get to your brain and be able to manage that inflammation. And then you bring in things like magnesium and zinc and vitamin B12 and riboflavin, folic acid. All of the things work together to stop and break that vicious cycle and allow for recalibration of the energy systems. And that's why I said, after an injury 4 years later, you still have an opportunity to change it, because most likely you're still in that neurocascade, neurometabolic, inflammatory, just repeated pattern. People who have persistent symptoms always complain of just being tired and having symptoms and pain, dizziness, and they can't get through their day. And sometimes it comes down to set boundaries, don't do too much. We're talking about very cardiovascular things too, because these are microvascular injuries. When you have that rapid acceleration and deceleration of the brain, you're tearing tiny vessels inside your brain. So we're talking about aerobic activity and nutrition are the two big dogs as far as actual intervention. Medication, Band-Aid. It's a Band-Aid. Can manage symptoms but doesn't fix anything. Yeah. So that's what we know right now about the omega-3s. But yeah, very, very good research on that.
Thank you.
Yeah, of course. All right. Anybody else have any thoughts?
Matt, I put a question in the chat just about this new research on medication that they've come about for
Oh, yes.
Alzheimer's.
Yeah, they approved one just the other day. Yeah.
How do you feel about that and where that's leading us?
Yes. So when we talk about When we talk about like later stage symptomatic degenerative diseases, one of the biggest challenges is relaying information about expectations and prognosis to family members and loved ones and all that stuff. And when we talk about the medications primarily are used to manage symptoms. Yeah. So everyone and their mother thinks that a medication is going to cure and reverse Alzheimer's. It's not necessarily the case. But what it can do is improve appetite, decrease agitation, improve sleep patterns, which improves comfort, decreases pain, and allows for sociability, which is one of the, in general, having friends and purpose is the #1 indicator of long life and good health. Above food, above exercise, above intelligence, if you got friends and you have a reason to live, you're gonna live. That's like, basically, that's the #1 kind of indicator we have. So as far as the medications go, they're going to allow space for the person to be comfortable and a better version of themselves for when family members are around, which family members deserve, right? And like the patient deserves. So I have no problem with those medications for the late stage stuff. The early stages, and we were talking about, I would love to prevent all this stuff before it ever happens. The retroactive versus the proactive medicine, it's playing catch up always, and you're never going to catch up to it. Nature is better than us always. It's always going to win. But yeah, the new one that came out is pretty promising for symptom management. Yeah, for the mid and late stages for sure. I forget the name of it. It starts with an A. Yeah, and they have some cool ones for CTE too, for the tau, the tau protein stuff. Definitely. And they're seeing, so like there's the unique tau buildup, but they're also pushing research toward, like I said, the microvascular stuff. The things that the tau is surrounding, like why did the tau come in the first place, is the question that they're asking now. To see maybe if there's a way to plug the hole instead of just bailing water out of the boat consistently. That's the challenge right now. Nice.
So we're over a little time, but does anyone have any more questions for Matt? Or Matt, do you want to put your contact information in the chat in case folks maybe want to follow up with you?
Definitely.
Great.
I'll do that right now.
You know, and we were talking about things that might help, but what things are harmful? You know, and the extensive drug use, for example, are there any data that would connect that with alteration of or promotion of an overactive response that produce the inflammatory elements or things of that nature?
That's a big question, and I don't know if I'm the exact expert on that one. My specialty is clinical intervention.
Right.
So I let the researchers do what they're going to do. So like, as far as I understand it, yeah, like there's a lot of foods that you can put in your body that's going to keep that inflammation going. Like you got your red meat, you got a higher omega-6 to omega-3 ratio is going to keep the inflammation pathway going. Cocaine, we know, has a pretty significant effect on vasculature and a very high risk in people with vascular abnormalities. alcohol, a depressant that's a big one. Tobacco has, that was another one I didn't mention. They make really good fake chew now. They make fake pouches. It's awesome. It's like tea bags. And tea, like green tea, is really, really good for you because it's got the L-theanine, which can help with melatonin production and sleep pattern. But yeah, like tobacco can mess with bladder function, increase fluid output it basically decreases hydration, which is massively important for brain health. What else as far as?
Yeah, no, that's okay. That's helpful.
Yeah. Environmental things too. So we see a lot of these guys spend a lot of time at clubs. So loud music and flashing lights can definitely be a trigger for symptoms. It's not far off from epilepsy, right? Like if you trigger a neurosensitive person, like their sensory processing disorders, it's going to set something off.
And my final question it has to do with sleep. And so, I've been pretty successful in my career because I don't need much sleep. but it has to do with, in essence, how your brain swells during the day, and overnight you dissipate that extra fluid and all, and how leaky your brain is. And so, as you described, after the choke game, you just went to sleep. And so there's an interaction here, probably acutely, but also if there's any information about the chronicity of that, and really how much sleep is involved in this on a routine basis, not just on an acute injury.
So they used to think that like you shouldn't go to sleep if you had a concussion because you might not wake up, right? That's outdated. The best information that we have right now tells us that in that first 24 to 48 hours, that calcium is influxing into the cell, and ATP production is starting to not be sufficient. So it's eating it all up. Everything is just depleting rapidly. And that takes about 3 days. So the first 2 days, sleep is very helpful. A full night of sleep and extra sleep. But after that, you start to get into a point where if you sleep too much, then you mess with your circadian rhythm, which impacts metabolism. So if you sleep more than 8 to 10 hours, you start having an opposite effect. So like naps, power naps, not necessarily a bad thing, because we're talking, you have to, if you don't catch this thing on day 1 or 2, which a lot of times we don't, and we can't, a lot of people just can't see it. If you don't catch it, then you're in that ATP deficit frequently. So like you need a nap, but if you sleep for 4 hours and then your rest and digest and fight or flight systems are off and your circadian rhythm's all out of whack, and then your melatonin production is wrong, your vitamin D gets out of the way. Vitamin D for brain healing and immunity. I mean, vitamin D is one of the biggest things. One of the like number one things I tell my people is just eat as many mushrooms as you can. and with mushrooms, like normal mushrooms, but the psilocybin mushrooms now, there's some pretty cool research on that too. So I'm excited to see where that goes.
Fascinating.
Yeah.
Well, thanks for continuing on. I'm sorry to keep everybody with these questions.
I love it. It's
fascinating
exciting
topic. Yeah.
I'm happy
Matt,
to talk to
there
everyone else. You got my.
There was one question in the chat.
Yeah, let's see. Love contact sports, but given this info, how can we continue to support them at schools like Andover? I think this is a question that I struggle with on a daily basis, because I love contact sports too. Contact sports got me to Andover, got me an excellent education, got me my jobs. Like it brought me out of my shell. I had like severe social anxiety as a child. I would never have dreamed of being able to talk to a group of people without football and the camaraderie and the family and the socialization. There's so many benefits that I think it's worth trying to find solutions to the few problems so that we can get all of the benefits that any organized sport offers, even down to the non-contact singles sport, like singles tennis, like everything has a benefit. For me, supporting the sport is being cautiously optimistic and being skeptical and calling it out and coaching up football. Like the way that we coach our athletes, like people don't get better if you don't know what's wrong with you. You got to know what's wrong so you can fix it. So we got to consistently expose and hold accountable people in positions of power, and encourage them instead of berate them. We're not trying to say that, because there's a lot of people. There's a guy that was at a conference one time that I went to who said that we should just fully out contact sports because it's just like no hope. We shouldn't even bother. And then some research came out the next year that said that we can catch concussions early and we could treat them. And he's like, oh wait, maybe I should reel back that book that I worked on for 5 years. But there's a lot of hope. There's a lot of potential. Like I said, if we can implement better protocols, then the impact is not as great. A concussion, a head hit, a subconcussive, or what they're terming mild, but it is a traumatic brain injury, it can be healed. So the problem is that we have them in too close proximity and too frequently. They just happen too much. So if we can fix those things, then a head hit isn't the end of the world. It isn't the end of a life. It isn't guaranteed negative outcomes. Of the 110 people in that BU study, 110 of them donated their brain because they had symptoms. But the other thousands, tens of thousands of people who played contact sports who don't have symptoms are out there saying, well, I'm okay. But nobody wants to talk about those guys. It's hard to talk about that. We can talk about it in a small group because we can have a personal connection. But if you say publicly that head hits are totally safe, then like the level of education in our country is just so vast. Like it's such a wide range. You've got to be careful with the public facing information. So a lot of times they just overshoot and they just totally unsafe. Don't do it. That's it. Should just be done. And
along those lines, I'm the associate editor in clinical orthopedics and related research. My overall editor, Seth Leopold, we have an editorial statement. So this is one of the leading journals that it's unethical for orthopedic surgeons to be advocate for this and be the sports doctor to take care of these patients because of these head injuries. So there's to your point, it's overreaction one way or another. And so I decide, okay, is it all right for my boss to say that? And I still on the letter saying that we shouldn't be playing football or supporting it. So it's a great question, and it filters in, and when you have a fiduciary responsibility for young, kids at school, and so I don't know what the status is for this kind of analysis at Andover, but I know, and Ernie's off the call now, but
I'm right here.
Oh, are you there? Oh,
Yeah.
sorry. But listen, I got body slammed in tackling drill at Andover, and our doctor was a pediatrician in Lawrence, and so they took me there, and he diagnosed me as having water on the spine. And of course, I had heard of water on the knee, which was interesting. So I thought that was pretty cool. But, it turned out I had a traumatic pars fracture in my lumbar spine. And so I have a little bit of a drag of my foot. It took 3 weeks. It healed up enough, and I went back playing you know, and I wasn't particularly good, as Ernie can tell you, but but I wanted to be. And it was okay because I went on and, you know, played baseball through college and beyond, but it was, but the medical care is terrible. Is the point of the story, and where we have a fiduciary responsibility. I never talked to my parents about this. They didn't know that I had that kind of injury. It was to the point earlier, you just suck it up and you go out there and you do it if you want to play. And that's the mindset. Anyway, sorry to make it a personal.
No, yeah, I mean, coaching is not far off from, like, there's a lot of overlap with parenting, and there's like, it's going to have an impact in the long term. And what was I going to say? I mean, it's true. You want to give these kids you want to give them everything and give them what they want, but you also have to be able to say, like, this is what's best for you. Like, you have to know that you know what's best for them at a certain point. There was another question. The follow-up was, if I had a son, would I let him play football? I wouldn't let any of my children play contact sports until they were in high school, because the likelihood of them playing professionally anyway is exceptionally small. And the likelihood of them playing is not going to decrease and might actually improve if they play non-contact, if they have a variety of skill sets and develop their develop their sport performance skills outside of contact before that. So, like, there's a lot of 7-on-7 leagues popping up, non-contact, flag football, skills camps. I'm all for that. I mean, that's what I did. I didn't play until I was high school, and I captained the Andover team. So, like, I played hockey, baseball, you know, soccer. You develop skills as a child. It's about variety, and in neuroadaptation, when you're growing and learning the simple principle of having to learn how to do things differently and to do different movement patterns, that's more impactful than anything. Like, Christian McCaffrey was a multi-sport athlete. You know, like, all of the best athletes that you see are multi-sport athletes. Mm-hmm. Tom Brady was a pitcher. You know, like, I would not let any of my children play contacts. There's absolutely no benefit to hitting other humans before the age of 15. It's stupid. It's poorly coached. It's dangerous. It doesn't make anyone better. It's glorified babysitting.
Yeah. How do you feel about having non-contact sports, but playing football in your middle school, in hockey, where, you know, they changed the hockey? I have 3 hockey players, and they changed the rules of non-hitting until you were a bantam. So in Pee Wee, you know, you could hit, and then a couple of years ago, they changed it not up till you got to that bantam level where you can start hitting. So how do you feel about that? Is it better for them to play, to learn the game, and then have non-contact, and then in high school you start the contact? Is that a better philosophy?
They're not gonna learn really. Because of we're talking about like a funnel, right? The kids that make it to high school, like, people who play varsity high school athletics are pretty good athletes. Like, people who play bantam and Pee Wee and youth leagues, it's just anyone who their parents don't know what to do with them. And you're not actually learning skills or technique or strategy. If the child is motivated to learn something, you can learn stick skills in a garage with a plastic stick and a tennis ball. You can, if they want to practice it on the ice with a stick and a puck, and they're really motivated to do it, and they're actually going to learn it. Yeah, they're going to learn stick skills, but they're not going to learn a lot of technique because it's too complicated. Hockey and soccer are very similar strategically in terms of like using triangular formations. And football, I mean, no child is going to learn football before they're at least 16. Like, it's just too complicated. Like you run an I formation, you hand the ball off, or you just huck it up in the air and hope for the best. There's not a lot of learning strategies there. It's mostly for the accountability. It's teaching kids to be accountable and to commit to something and to work hard at it. And that can be done in a lot of ways that don't involve contact. The organized sport we talked about, there's benefits to it. So, there's, if you think it's up to the discretion of the parent. It's gonna be different everywhere in the world. Every state is different. You have different cultures everywhere. There's, different gender roles in different places. And that was a question I saw just popped up about that. Actually, are men more hardwired for combat? Grandson, 6 months, punching in the air. 6 months, you've already kind of been exposed to some stuff. Toys are gendered as early as 1 year old. Clothes are gendered since birth. That's all going to play into it. Males, testosterone does have an impact on physicality. Absolutely. The violence, not necessarily, but aggression and use of physical force. I mean, we can see just in the anatomy and physiology of males, we have more muscle mass and density naturally. Females can gain that, but it takes harder work. The shape of our bodies evolutionarily is designed for hunting and fighting and protecting, whereas female bodies are designed to carry children and not much else. And that's why every pubescent girl soccer player tears their ACL. It's because their hips are spreading to hold a baby, and then they don't have any muscle control over valgus angle of their knee. But yeah, like the genetic makeup of males and females can play into aggression and all that stuff, but it can also be taught. It's nature and nurture. There's never one or the other. There's plenty of very, very passive, very pacifist kind of males in the world, and that's learned and genetic to a certain extent. So it's a big question. It's hard to answer, but yes. Anything else?
Very much. I really enjoyed it, and it's nice to meet you. And
yeah, you too.
Yeah.
Keep in touch, everybody. Please reach out. You got my contact info. I'm happy to talk to you. What was that?
Thank you so much. This was great.
Thank you.
Yeah, you're welcome. You're very welcome. Enjoy the rest of the weekend, guys. Have a good one.
Thank you, everyone.
Thank you.
thanks, Ernie. Good to see you.
Good to see you, John.